Hello, everybody. Welcome back to Health Economics for Health Economics Lecture 16, Technology and the Price of Health. I, as per usual, am your instructor, Liam Puckneys, and let's get to it. So, as you may remember from the first lecture in the course, healthcare costs are rising. So, in 2008, one out of every $6 spent in the US was on healthcare. That's up from one out of every $20 that was spent on healthcare in 1960, right? So that's a significant increase in healthcare as a percentage of GDP, right? And by 2023, in case you're curious what's happened since 2008, healthcare is still about 1/6 of GDP, a little more than 1/6 of GDP. But the size of the healthcare sector is a whopping $5 trillion a year, which comes out to about $14,500 a person, which is right. That's $1,400, $5,000 in medical care expenses per person per year in the U.S., which is insanely high, right? So, right, you may remember this graph from lecture one, right? The little circles are health expenditure as a share of GDP, right? So it's going up from 1960 to 2008, right? So we start at just about 5%, and then by 2008, we're just over 16% of GDP is spent on healthcare. Now we're at like 17.5%, so it's still going up. Perhaps, that's still going up. And then the triangles are GDP, right? So we're getting richer, right? So we have more money to spend, and we're spending a bigger share of our money on healthcare, meaning our healthcare costs, total healthcare costs, are going through the roof because we both have more money and we're spending proportionately more of that money on healthcare. So let's talk about what goes into healthcare costs and the difference between health costs and healthcare costs, because that's an important distinction. So in many ways, the cost of health care is less important than the cost of health, right? So ideally, right, if we think about this from a Grossman model perspective, health care is an input into health. And what we care about is whether is people being healthy, not necessarily having access to health care. Now, having access to health care may make people healthy, right? Better health care may make people healthier. But what we really care about at the end of the day is making sure people are healthy, right? If tomorrow an angel came down and said there is no more disease and there are no more broken bones and nobody will ever get hurt again, and we didn't need to spend any money on healthcare ever again, I think everybody would be pretty thrilled with that outcome, right? We would nobody anywhere would have access to would have access to healthcare anymore because it would no longer be necessary. So it's important to sort of break down healthcare costs into what's driving the increase in healthcare costs, right? Is the price of healthcare rising, or is the quantity of healthcare we're purchasing rising? Because both of those go into expenditures, right? Expenditure is price of care times quantity of care. And so if the price is rising, that's probably bad. But if the quantity of medical care is rising, that could be good, could be bad, depends on why it's rising. And remember, at the end of the day, we actually care about the cost of health, not about the cost of health care. So, prices rising is probably bad, right? If something costs more, right, effectively, right, if prices go up by 5%, we can purchase 5% less of that thing. Right, and that's overly simplistic, right? You all took Econ 200, you know that's overly simplistic. But in general, higher prices is bad for consumers. But quantity rising is potentially good, right? If, for instance, if healthcare has gotten more effective, right? If there's new health technologies that are more effective, that might mean that investments in health become more efficient, right? And so people invest more in care, right? This is sort of consistent with the Grossman model again, where the marginal returns to health increase, right? This is like that jogging question, right? If the returns to jogging increase, do people spend more time jogging? The answer is, maybe, maybe not, but probably, right? Similarly, if the returns to buying healthcare increase, people may buy more healthcare, right? That makes sense, right? Right? If we're in the Middle Ages and the best cure you have are a bunch of leeches, right? You're probably not going to be you who knows that leeches aren't very effective. You're probably not going to spend a lot of money on leeches. But if in the modern day, right, if somebody's like, hey, we can do, we know how to cure your condition, and instead of leeching you, we can give you open heart surgery, you'd probably pay a lot for that open heart surgery. Now, so in general, you might think quantity rising is potentially good. Now, quantity rising could be bad if, for instance, we're less healthy now, and that's why healthcare costs are rising. Maybe Americans, America, I think obesity is starting to fall now, but for a very long time, obesity was on the rise, right? And so if healthcare costs are rising because obesity rates are rising or diabetes rates are rising, that's not necessarily a good thing. But again, that's different than healthcare costs rising because prices are rising, right? If healthcare costs, if healthcare spending is growing because people are getting older, and older people, right, a greater percentage of the population is old because birth rates are falling, and also people are living longer, and so we have a larger share of the population that's old. Well, quantity is going to go up, and that's not necessarily good or bad. It's just that, we have more old people now, which is the result of good things, right? A falling death rate, right? Longer life expectancy, that's good. But we're going to spend more on healthcare if the population gets older just by, having more old people. Old people demand more care. Quantity rising could be actively bad, though, right, if it's being driven by moral hazard, right? So is it possible we're actually over-innovating? Are we getting too much healthcare, right? You may remember the hospital arms race from the lecture on the hospital industry, which is where hospitals, right, they don't compete on prices because everybody's insured, either explicitly or implicitly. And so the way they compete is by having the best medical services. And they may overinvest in medical services to compete with each other because they know the insurance company is going to foot the bill at the end of the day, and so patients aren't price sensitive. And so moral hazard is going to be a frequent theme in this lecture, as well as the coming lectures, right? Moral hazard is a huge problem in healthcare policy. And it's going to really shape whether we think is the rise in healthcare costs, is it efficient or is it inefficient, right? Is our rising healthcare, right? Moral hazard is going to determine a lot of that, whether the rise of cost is a good or a bad thing. So let's start I already went over a lot of these, but just to show them on the screen and go over them again. Quantity may be increasing. Right? Why is that? People may be demanding more care. Well, as we discussed, people might be getting old, right? Old people demand more care, right? The population is getting richer, right? As people get richer, they spend a higher percent of their income on healthcare, right? Healthcare is a normal good. And it's a normal good, right? As people get richer, they demand more of it. So it's a normal good. But there's evidence that healthcare may be in some sense a luxury good, where you may spend more of your expenses. You may spend more money as a percent of your income on health the more money you have, right? So a way to think about this is if you know really rich people, they spend a lot of money on exercise classes and things like that, right? They not all of them, but I know a lot of rich people who spend a lot of money on going to Equinox, right, and Soul Cycle, right, doing yoga. Right, these are really expensive things, and so there is some evidence that suggests that healthcare isn't just a normal good; it's a superior good or a luxury good in that you buy more of it the richer you get, right? And so quantity may be increasing just because the U.S. population is getting richer, and as we get richer, we spend more on healthcare. Quantity demanded could be increasing because of insurance, right? More of the population is insured, which means more of the population is subject to the dreaded moral hazard, right? You're going to be sick of hearing those words by the end of this lecture, right? They're over-consuming care because they're insured now. The insurance company is paying the price instead of the individual, or the insurance company is paying more of the price, right? And so people are still price sensitive, but they're less price sensitive than they would otherwise be. And then lastly, as I mentioned, it could be that medical care is more effective, right? If healthcare is more effective, people may demand more of it, right? If the most a doctor can do is give you some leeches, you're probably not going to pay very much for that. Now, are rising costs bad? I've been hinting at this, but it may be that rising costs aren't bad, right? So if rising costs are being driven by rising demand, maybe not bad, right? And maybe good if rising costs are because healthcare is more effective. And so, right, like we'll go over this later, but there was no cure for Hodgkin's, a disease called, I think, Hodgkin's lymphoma. I think we'll get to it later. It's in the slides. But there are diseases that we just didn't have cures for, right? HIV, for instance, right? First few years of the HIV epidemic, there was really no effective treatment for it. Now we have treatments for it that are effective. They're not 100%, but they're not cures, but they're a lot better than what you would get in 1980. And so maybe healthcare expenses are going up because we can now treat conditions we couldn't treat before, right? Cancers that were seen as a death sentence a few decades ago are now treatable. That's really good, and it also means healthcare costs go up, right? And that's actually a good thing. Now, it could, on the other hand, it could be that the rising costs are driven by rising prices, and rising prices are usually bad for consumers. And if we think about this through the perspective of the Grossman model, again, the price of healthcare goes up. That means health is more expensive to produce, right? It's more expensive to be healthy, which means people either need to reduce healthcare expenses or spend more on healthcare and reduce spending on other things, right? The home good in the Grossman model, in order to stay healthy, right? So prices rising is probably bad. So are prices rising, right? There are a few things that could make prices rising, right? Maybe resources are more expensive, right? Maybe there's a shortage of physicians, which there definitely is, right? Maybe the American Medical Association is too restrictive in licensing physicians, and they should let more people be doctors, right? Maybe if we go back to that sort of quality trade-off that we talked about in the number of doctors on the market, maybe we're too high on quantity and or we're too low on quantity and too high on quality, right? There's a more restricted supply of doctors and it's getting more restricted over time. Or maybe just the price of the stuff going into vaccines, the stuff that goes into making pills, maybe that's gotten more expensive over time, right? That could raise prices. It could be that markets are less competitive, right? So I already touched on the physician market, but there could also be, right, there have been lots of hospital mergers recently, right? Maybe hospital mergers are raising prices for everybody because now hospitals have more monopoly power. Now, you may be skeptical of this because you may remember that hospitals don't necessarily compete on price because of insurance companies, right? The way hospitals compete is really complicated, and it's partially through quality of care. It's partially through it's a little bit through price, but it's also partially in sort of which hospitals are in network or out of network for your insurance coverage, right? So, but it could be, there are reasons to doubt that or be skeptical that it's hospital mergers, but it could definitely be hospital mergers that are driving higher prices. And it could also be expensive new technology, right? So if you think that, okay, maybe it's not that hospitals are driving up the prices per se, but they're competing for really high quality technology, maybe only marginally effective technology. Maybe the new MRI machine is only a little better than the old MRI machine, but costs 3 times more, right? And so, we have the moral hazard, right? The hospital arms race, right? Or the medical arms race that the hospitals engage in, right? Could be due to moral hazard that physicians are supplying more and more medical care, and companies keep coming up with new drugs, which are only marginally more effective. And again, so expensive new technology is good if the expensive new technology is worth it. Right, so for example, right, Wegovy, Ozempic, right, these are basically miracle pills that really help people and are basically they're maybe not perfect cures, but they're going to make a huge dent in the obesity epidemic, right, which is going to really improve health for most Americans. At the same time, right, there are definitely pills that are there are blood thinners that may be a little better than aspirin, maybe, emphasis on maybe, but cost 5 times more or 10 times more, right? And so there are new technologies that are worth it, and then there are new technologies that are only marginally more effective and aren't necessarily worth it. And we'll go into how next lecture we'll go into thinking about how do we price these technologies and is a new technology worth it. But just throughout this lecture, just remember that just because a new technology has an effect does not necessarily mean it's worth it. Especially if the insurance is footing the bill, and so there's lots of moral hazard and the patients aren't paying for the cost of their own care or only paying for a small portion of their own care. So let's discuss medical inflation. So what is medical inflation? This is the rise in the price level of medical goods and services, right? So this is how we're going to tell if prices are rising. And then a medical care consumer price index, or a CPI, which you should have seen in your macro classes, it's a measure of medical inflation, right? So this is a CPI, a medical care CPI is how much more does it cost us this year to buy the same medical services we bought last year. And the way they do this is they create a bundle of medical services. So the cost of a checkup, plus the cost of vaccines, plus the cost of a surgery, right? And times the odds you're going to get those things, right? So they're going to try to make it so these bundles are representative of what the average person is buying, right? So the average person is going to buy, for instance, right, maybe 1/20th of a migraine pill, for instance, per year, right? Because maybe 1 in 20 people have migraines. Don't quote me on that. I'm making that number up. And so, right, you're going to try to get a bundle of medical expenses, weight it by the number of people who are spending money on those things, and so you get a whole bunch of medical procedures, drugs, other healthcare and medical related technologies and procedures, weight them by how many people in the population are using them, multiply them by price, and then track how the price of that total bundle is changing over time, right? So how do you calculate a medical care CPI? Well, the same way you would calculate any other CPI. You're going to use the Les Payres index. And that can get pretty complicated, but let's assume there are only two goods in the bundle, right? There are two goods, A and B. And 0 denotes, right, a subscript of 0 denotes the quantity, it denotes yesterday, and a subscript of 1 means today, right? So Q0A and Q0B are the quantity of goods A and B in the bundle from yesterday, right? The P0A and P0B are yesterday's prices of A and B, and P1A and P1B are today's new prices for A and B. So the first thing you'll notice, and then the way we're going to calculate the CPI is via this equation here. Now, the first thing you should notice about it is we actually use the same quantity in both both calculations, and that's because we know that quantity changes with price. And so if we use the quantity today, right, let's say the price of good A goes up relative to good B, right? So then we'd buy more of good A, we'd buy less of good A and more of good B, and that would understate inflation. And so instead, we use the quantity from yesterday in both the numerator and the denominator. But we take the price today of good A times the quantity from yesterday of good A, plus the price today of good B times the quantity from yesterday of good B, divide it by the price from yesterday of good A times the price from yesterday, the quantity from yesterday of good A, times the price from yesterday of good B, times the quantity from yesterday of good B. So when we do this, what does the medical care CPI look like compared to other metrics of inflation, right? So here we have 3 metrics of inflation. We have the medical care CPI, right? That's the dotted line here. Then we have all goods, right? That's the black line here. And then we have clothing, which is the gray line here. So the first thing you should note, right? The price of clothing has actually gone down over time, which is awesome, right? Clothing's getting cheaper. Woohoo! Amazing. In general, things are getting more expensive from 1985 to 2005, right? We have inflation of, 3.5%, 2.5%, right? Which Federal Reserve, I think, likes inflation around 2.5%. That's their official policy. So But you'll notice that the medical CPI is consistently higher than the general CPI, right? In fact, in every year from 1985 to 2000, let's say 2003 or 2004, the medical inflation was higher than overall inflation. So this is indicating, yes, prices are going up, but this is not enough to explain all of the increase in the medical care expenses. And on top of that, right, so even though we can see, yes, there's inflation in medical prices, there's a problem that's true with all medical indices, including the medical care CPI, right? There's a problem with all inflation indices, including the medical care CPI, which is, how do you interpret them? So a basic interpretation of a medical care CPI is that a 5% increase in the Les Perez price index means that consumers are 5% worse off, right? That's because the things they want to consume are 5% more expensive, and this is assuming wages are constant, right? So in theory, right, if wages are going up at the same rate as inflation, then, inflation is all nominal and shouldn't have any effect on the real world. Now, that's not true, right? It turns out that even if wages are going up at the same rate everything else is, people still hate inflation. But we're not going to go into that in this class. That's beyond the scope of this course. Suffice it to say, there are entire fields of economics devoted to this, and many people have won Nobel Prizes for discussing why inflation actually matters if wages are rising at the same rate as everything else. But the medical care price index, right? This is only the price of medical things. So maybe doctors' wages might be included in this, but the wages of the people we should really care about, which as far as I'm concerned are economics PhD students. Their wages are not included in this, right? So the most basic reading of an increase in the Les Perez index for the medical care CPI is that a 5% increase in that index means I'm 5% worse off because the things I want to consume are 5% more expensive. However, there are problems with this interpretation, which hopefully this will be ringing a bell from your macro courses. And if not, well, let's remedy that. So this index is not going to reflect product improvements, right? So if for instance, Band-Aids, right, might be in the medical care CPI, right? But if Band-Aids have gotten better over time, right? So this is just something I've noticed at the hospital, right? So casts are less bulky than they used to be, right? So if casts, let's say there's a new cast that's less bulky than it used to be, and so it weighs less, it's more pleasant to have on, right? It doesn't get in the way as much, but it costs more, right? It's still, right, the cast from, let's say a new cast comes out in 2003. So from 2002 to 2003, the price of the cast goes up. But that's because, the quality of the cast also goes up, so you're not really buying the same cast, even if it's made by the same manufacturer, right? If Band-Aids, right, if Band-Aids come out with a new improved Band-Aid production technique, and Band-Aids, right, they fall off less from one year to another, yes, the price of Band-Aids may go up, but the quality of the Band-Aid goes up as well. So the medical care right, the Les Perez price index can't capture product improvements. It also doesn't capture new treatments that were previously unavailable. So, for example, polio vaccines replacing iron lungs. Right, polio vaccines are way more effective than iron lungs. They're way more pleasant than iron lungs. Right, an iron lung is a giant machine that basically forces you to breathe if you're paralyzed. And after the polio vaccine came out, we didn't need iron lungs anymore. But so what do you do with the iron lung, right? It's still in the medical price index, right? Because, in 1914, people still needed iron lungs. At what point do you take that out and replace it with the polio vaccine, right? That's a difficult question. Like, when do you replace things in the bundle of goods is a difficult question. And then there are also improvements in existing treatments. So like blood transfusions are much safer due to better screening, right? Should we include that in the price, right? So same procedure, a blood transfusion, again, may cost more, but it's way safer now, right? You're much less likely to get HIV from a blood transfusion, for instance, now than you were in 1980, for instance. So right, it can be difficult to interpret a medical care CPI. So as a last note on the CPI, let's discuss new technologies in the CPI just to really hammer this home. So consider the cure for Hodgkin's lymphoma, right? So this is a form of lymphoma where before 1950 there's essentially no cure. And so the price in 1950 for a cure was essentially infinite, right? Nobody could afford a cure, right? There's if you've seen the Justice League Unlimited cartoon, there's this great, or maybe I don't remember whether it's Justice League or Justice League Unlimited, but it's I think it's Justice League Unlimited, where Lex Luthor gets kryptonite poisoning because he carries around a hunk of kryptonite all the time to ward off Superman. And at some point, he discovers it's poisoned him and given him cancer. And he has a fear. He gets furious at Superman. He says, "This is all your fault, Superman," because he's Lex Luthor and he's a total jerk. And then he throws the doctor has handed Lex Luthor a medical chart, and he throws the diagnostic report at the doctor and says, "I'm the richest man in the world. Price is no object. Get me a cure for this." And the doctor says, "I'm sorry, your money can't solve this. There's nothing we can do. We have no idea how to cure this," right? So the price of a kryptonite poisoning cure for Lex Luthor was infinite. He was the richest man in the world, and he couldn't afford it because it didn't exist, right? So on a less dramatic level, and perhaps a more personally tragic level, now if you had Hodgkin's lymphoma in 1950, you could be the richest man in the world. It wouldn't matter. A cure didn't exist. Go to 1913, a cure exists now. It's expensive, right? It's $50,000, right? So that's pricey, right? It's a pricey cure. But the price is finite, and the cure exists, and so it's now, the quantity consumed is now positive. And so one way you can think about this is between 1950 and 2013, the price of curing Hodgkin's lymphoma went from infinity to 50,000. Which is an infinite reduction in the price, right? The percent of the price, right? So, right, that's a right. So how do you account for that in a price index, right? This is really hard, right? We have the same problems with overall inflation, where the year the iPhone comes out, how do you account for the fact that there's now an iPhone? And there wasn't one before, right? How do you include that in inflation calculations? Do you count the iPhone as a cell phone? Well, that's not really right. The iPhone's a lot better than a cell phone. Do you say it's a BlackBerry? Well, kind of, but the first iPhone was way better than early BlackBerries, right? Or the iPhone outcompleted the BlackBerry, right? There's a reason you don't see those anymore. And we have the same problem for medical care. And medical care is a super innovative industry. And so, right, so my new migraine pill, like Qulipta, costs $1,400 a month. My old migraine pill probably cost about $200 a month, right? That's way cheaper, right? Right, but the new migraine pill is way more expensive. It's also way more effective, right? And so, right, so how do you account for new technologies and improvements in technologies in the medical care CPI? It's really hard. And so if the medical care industry is more innovative than the economy on the whole is, and there's a lot of reason to believe that it is, it could be that the medical care CPI is higher than the overall CPI, not because the price of medical care is actually rising properly understood, but it's that, yes, prices are getting higher, but the price is getting higher because the quality of medical care is actually improving. And so, right, medical care prices are enough. Even if you take this at face value, it's not going to be enough to explain all the rise in what we're spending on medical care. But there's also reason to suspect that the medical care CPI is overestimating the amount of inflation, because it really struggles to account for improvements in treatment and new innovations. So, and then just one last note on the price of healthcare. What's been happening to the price of health over this time period, right? So this is looking over, I think, 7 years, 1984 to 1991. Then we're going to look at the price of surviving a heart attack. So, right, so we have life expectancy after a heart attack in years here, right? So in 1984, after you had a heart attack, your average life expectancy was about 5 years and 2 months. By 1991, it's 5 years and 10 months, right? So life expectancy after having a heart attack had improved by about 8 months over those 10 years. Now, about half of that was due to overall improvements in life expectancy, which means about let's just say, for the sake of argument, that the rest of that is due to improvements in heart attack treatment. So that means you're getting about 4 more months of life on average from a heart attack treatment in 1984 as you are in 1991. At the same time, the cost of a heart attack treatment is going up a lot, right? Over 7 years, it goes from $11,000 to $15,000, right? That's a lot more money. So if you're looking at a medical care CPI, you'd be like, ooh, price of a heart attack treatment, that's going through the roof, right? That's a huge percent of increase, right? It's gone up 30, 40% in 7 years. That's insane. But we care about the price of health, not the price of health care. So what happens if I agree, that's a big price increase, right? $11,000 to $15,000 is a really big price increase. But 4 more months of life is nothing to sneeze at. So let's see how much more we're paying per month of life, right? So, right, the cost of treating a heart attack go up, but so did the life expectancy of heart attack patients. And after you account for the increase of life expectancy, the fact that health was improving over this time period for heart attack patients, the price of having a heart attack dropped about 5% per year when you account for increased life expectancy, right? So actually, even though a medical CPI would say, hey, the price is going up over this time period, when you look at the price of health as opposed to healthcare, the price of health was dropping even though the price of healthcare was going up, because even though the treatments were more expensive, they were more effective, right? And so this is a really good example that sort of shows the price of health versus the price of healthcare.